Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I am your host, Amanda Mixon, and the current president of RhAPP. We are at our 6th Annual RhAPP Conference, where the energy, the education, and the engagement has been just absolutely unmatched. Hopefully you were here for the conference, but if not, we are going to fill you in on some of the exciting sessions, some of the really important topics that have been explored while we're at the conference. So today, we're going to dive into this intersection between pulmonology and rheumatology, specifically talking about interstitial lung disease with a spotlight on PH-ILD, so pulmonary hypertension in the setting of interstitial lung disease. This is really complex, high-stakes clinical challenge that really demands this multidisciplinary approach. So to explore this topic, I'm joined by a phenomenal guest and friend of RhAPP, Jessica Glennie, a pulmonology expert and leading voice from our sister organization, APAP, which is the Association of Pulmonary Advanced Practice Providers. Together, we're going to unpack the diagnostic nuances, management strategies, and collaborative opportunities that can elevate care for patients with ILD and PH-ILD. So, Jessica, do you want to do a quick introduction? Because maybe some of our folks don't know who you are.
Yeah, absolutely. Well, thanks for having me here, Amanda. This is a pretty complex area. This could take up a couple podcasts, honestly. But I'm Jessica. I'm a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio. I work in the Interstitial Lung Disease group there. I've been there for about 10 years. That's really my main focus. But of course, I see patients with connective tissue disease, and they have overlapping pulmonary hypertension very often. And so I also care for people with pulmonary hypertension as well.
Well, and, again, it's just so important, I think, that we have this cross-collaboration because we share these patients. And so, obviously, as you know, ILD we can miss it early on. What signs or symptoms should rheumatology APPs look for in their connective tissue disease patients that might prompt us for an earlier pulmonary referral?
Yeah. So your patients can sometimes have a double whammy of pulmonary issues, so interstitial lung disease or pulmonary hypertension. So things to look for are shortness of breath. So asking your patients when you're meeting with them, especially if you know that they have a connective tissue disease that can cause one of these pulmonary issues. Are you feeling more short of breath lately? Are you having trouble doing your activities of daily living, going up and down the stairs, walking, your dog, things like that? Specific to interstitial lung disease, cough. So they can have kind of a dry cough. Fatigue is a big one for both PH and interstitial lung disease. And then, looking for like hypoxemia or asking them, if they do check their oxygen. Maybe they wouldn't, but, a low oxygen in the blood would be another thing to look for.
Okay, so that's, I think, so important. Even thinking, because I know sometimes I'll ask people, are you short of breath? And they're like, no, I'm not short of breath. But then if you really kind of, maybe then I'll listen to their lungs and I'll hear inspiratory crackles. And I'm like, you're really not short of breath? Well, is it harder for you to go up the stairs? So it's like asking the right questions too, right?
Absolutely. So yeah, sometimes, especially if it's an older patient, they might just think, oh, I'm just getting older, And so you sometimes have to push them and say, well, how are you doing? Something that creates a little bit extra cardiovascular, kind of output, going up the stairs, carrying a laundry basket upstairs or carrying anything, period. And they might say, yeah, I used to be able to do that 2 years ago and now I can't.
Absolutely. Well, okay, so we've asked the right questions, maybe we've heard something. From your perspective, what diagnostic tools like high-res CT, pulmonary function tests, what do you want us to order for you so that we can help, navigate the referral, get the patient in, et cetera?
Yeah. So you highlighted one thing, which isn't a diagnostic test, but, it's part of your physical exam. I want you guys to use your stethoscope, listen to the bottom of the lungs and ask the patient to take a big inspiratory effort. And especially like on the sides as well of the chest, down at the bottom. Sometimes you can hear those crackles better on the sides, but you'll hear these inspiratory crackles, kind of sounds like Velcro, or Rice Krispies. I hear different people say different types of things. So that's important. PFTs and a high-resolution CT are important to assess for interstitial lung disease. The PFTs can also give you clues into pulmonary hypertension. So these patients with interstitial lung disease will find inflammation or scarring patterns within their lungs on their CT. And you guys can order that if you feel comfortable with that, or refer over to us if you'd rather us do that. The PFTs are really important. So you'll see a restriction. The vital capacity will be lower than predicted, and then the diffusion capacity as well. How well that oxygen is able to transfer from the alveoli into the capillaries within the lungs, that will be reduced in interstitial lung disease, and very much reduced oftentimes if you have interstitial lung disease plus pulmonary hypertension. So that those are things that we're really looking for. And then I think one thing that you guys are really good at ordering, especially for your scleroderma patients, is the echocardiogram. We have screening recommendations for once a year to do an echocardiogram. That's a great screening tool for pulmonary hypertension. Since we're talking about PH-ILD today, I'll throw that in there. So, on our echocardiogram, we can see changes in the right side of the heart, either the function or maybe the structure. It'll be dilated. We can sometimes see an estimate of the right ventricular systolic pressure, or some other things like the things relating to the structure, or something called TAPSE is something that is often a measurement that relates to the right ventricle and how well it's functioning. So these are big clues for us for ILD and PH.
Super interesting. And I have to be honest, this is going to be embarrassing, but if I think it, maybe other people do. I guess I wasn't aware that people could have PH-ILD. Are they two things? Is it one thing? Can you explain that to me?
Yeah, absolutely. I think for, many of the rheumatology providers out there, you may be thinking, well, gosh, I send one patient to pulmonary or cardiology or whoever it may be, and they put them on one type of medication, but then another one that I send over, they don't put on that medication and made my other patient feel good. Why aren't they using that for this patient? So it is a bit complex. So there are different types of pulmonary hypertension. So PH-ILD falls into what's called group 3. So basically what happens is, and to your point, I mean, they are two different things, but they impact each other. So the interstitial lung disease causes inflammation or scarring in the lung, and we know that causes this scarring of the tissue. It can make your patients hypoxemic, so that low oxygen in the blood can cause vasoconstriction of the pulmonary vessels, which can make your pressures go higher. But then there can be actual damage that occurs from the fibrosis to the pulmonary vessels. And so I describe it to my patients as if you have like a 6-lane highway and you destroy 3 of the lanes, and now you have the same number of cars trying to go through 3 lanes rather than 6. There's a lot of congestion. So, the same thing with this. You destroy a lot of the blood vessels. You're still trying to put the same amount of blood through, less blood vessels, and so the pressure goes up and you get congestion in there. And so that's basically what happens in PH-ILD. And just for reference, there are different types of pH. So we also have group 1, which is PAH, which is the most common that you would read about if you looked online. It's the one we have all the medications for. It's more rare, but it can be caused by autoimmune diseases as well. So our, the biggest one being scleroderma. So there can, in group 1, there are changes that remodeling and constriction and stiffness that occurs to the pulmonary vessels caused by the autoimmune disease. So in those types of things, we could use different types of medications for those than we can for PH-ILD. We've found that the medications that we use for group 1 don't help for group 3 or can be harmful. Apart from one of them, which we can go into, but so it's very important to kind of parse out what type of pulmonary hypertension they have. And I'll just mention that your patients could also have group 2, which is pulmonary hypertension related to left heart disease. And this is very common as we age. It's the most common cause of pulmonary hypertension, in fact, and so. You can have somebody with some systolic, heart failure, or more commonly diastolic dysfunction. Your older patients who've had maybe, essential hypertension unchecked over time can get stiffness of that left side of the heart. It doesn't relax as well, and that blood just backs up into the pulmonary vasculature. And so, especially your older patients, like if you have a patient with RA who has UIP, you might do a right heart cath and find, well, maybe they don't have, pulmonary hypertension related to their interstitial lung disease. Maybe it's more, they have this left heart disease. So if you have a patient that has MI in the past, has hypertension, they're older, thinking about that. And we do not want to give the medications to those patients. It actually makes them worse and causes pulmonary edema and pulmonary congestion. So there's a lot to think about when it comes to these patients. And I think it just highlights, I'm sorry, I'm being so long-winded on this point, but I think it highlights how important it is to get your patients with PH into, with a doctor that is a pulmonary hypertension expert, or even if they're close to a center of excellence for pulmonary hypertension, because you have to really parse out what type of pulmonary hypertension your patient has, or is it a combination, or which one is most dominant. It's really going to drive the treatment.
Wow, that does sound extremely challenging.
Yeah, it is.
And I'm, again, so appreciative for the collaboration, because in rheumatology, we really don't know a lot about that, and on that note of this PH-ILD, right, that adds this whole nother level of complexity. As a rheumatology APP, what are the clinical clues that might suggest maybe that pulmonary hypertension is developing in our ILD patients?
Yeah. So if your patient is getting more short of breath, more fatigued, more hypoxemic, I think hypoxemia is a big one, because your patients with ILD, maybe the ILD is getting a little worse. They may be more short of breath and more fatigued, but there usually is a pretty significant change in their oxygenation if pH is developing. They can go from on their walk needing 2 liters to all of a sudden needing 6 or 15 liters non-rebreather if on their walk. If you are looking at the PFTs that are being done and you're seeing that their vital capacity is staying the same, but their diffusion capacity is really starting to drop more, that's a clue, because the FVC kind of is telling you their lung disease, their interstitial lung disease is stable, but that DLCO can be impacted by the pulmonary hypertension. And so you're seeing that discrepancy there. Your patients, so if it has gotten a little too far, this is a bit too late, but if they're having right-sided heart failure types of symptoms, so lower extremity edema and things like that, you're kind of catching it a bit late at that point, but those can be signs as well. Asking them about their weight, are they holding onto fluid, are they having lower extremity edema, and things like that.
Wow. I mean, again, and hopefully, these patients are being monitored by both us and pulmonology so that, these things are caught early, to your point.
Yeah.
You mentioned already some therapies.
Yeah,
So I kind of
yeah.
want to talk about that a little bit. There's obviously this growing pipeline of treatments for PH-ILD, which is exciting. What's the most important for rheumatology APPs to understand about these treatments and how they're integrated into care?
Yeah. So, it comes down again to understanding what group they're in. And, you guys may not, know all the intricacies of all the medications, but knowing that, the pulmonologist or the cardiologist that's taking care of that patient is really tailoring the therapy to what group they're in. So if you have a scleroderma patient that has group 1 PAH, and it's really much more kind of like group 1, there are a number of therapies. There are basically 4 medication pathways: nitric oxide pathway, endothelin pathway, prostacyclin pathway, and a new pathway, which is called the activin signaling pathway. And it's too much to go into all the medications, but they can be on a number of these different medications. If they have group 2, you guys can really help to tell them, keep your blood pressure under control, low sodium diet. And they'll say, oh, I don't put any table salt on my foods. Well, it's not just the table salt. It's really looking at sodium that's in those frozen and packaged and restaurant foods and things like that, and keeping that under 2,400 milligrams daily. And then keeping up with their cardiologist and pulmonologist and making sure that they're on the right diuretics and right optimized cardiology kind of meds. And then to really the PH-ILD, which is what this talk is mostly about, they can be on an inhaled medication, so inhaled treprostinil. This is the only approved medication for PH-ILD. We have found that the other medications that we use in group 1 can make things, actually, their hypoxemia worse. So really, the reason for the inhaled is we're just getting that medication down to the working parts of the lung, because these patients have scarred lung tissue. We don't want to open up blood vessels in areas where they can't transfuse oxygen into those blood vessels. That will just make their hypoxemia worse. So that's kind of the reasoning for the inhaled. And this is just a vasodilator that helps to open up those blood vessels, decrease the pressures. We know that it helps them to walk further on their 6-minute walk distances. So patients may have a better quality of life. They'll be able to do more at home. Maybe they'll be able to, cook for themselves, things where they weren't able to do before. It also lowers one of their biomarkers called the NT-proBNP, which is a biomarker of heart failure, of stretch on the right ventricle. And so it's important to get patients on these therapies to try and keep them from going into heart failure, and help them have a better quality of life.
Wow, thank you so much for explaining that. You actually make it sound like simpler than I'm sure that it actually is, because these patients are really complicated. So it sounds like they could be on multiple therapies, is what you're saying.
They can.
Again, I think it just also highlights the importance of this cross-collaboration. So how do you think we can optimize that? Because it would be lovely if we had access to you, or we're close to Cleveland Clinic or something. But what if, there's more remote people and, they're practicing. So how do we do it? How do we do a better job?
Yeah. So I think come to RhAPP and APAP and meet with other people, other APPs that work in rheumatology or pulmonology. Have somebody that you can have on dial, right? Or message with, to collaborate with. I think, and I didn't touch on this, but the gold standard for assessing for pulmonary hypertension is a right heart catheterization. I think that is quite important to at least know if there's a cardiologist close to you who does right heart caths that you can refer your patients to, or a pulmonologist that you can work with to refer them over to. So knowing at least, what your resources are in your area. And then you can go to either the Pulmonary Fibrosis Foundation and find centers of excellence for ILD, or PAH PH association, and they have resources to find areas where there are PH clinics and physicians close to you.
Awesome. And, again, to highlight that, I think that's why it is so important to come to these kinds of meetings, because we connect with other people. And even if you're not close to an expert, having that cell phone that you can just, pick up. And I have to tell you, even PFTs really confuse me. All the numbers, I don't really get it. But I can text it to a pulmonary colleague that is an ILD specialist to say, what does this look like to you? Can you just give me the Reader's Digest?
Yeah.
Really dummy it down for me so that I understand, so that I can tell it to the patient. Because I think part of the problem is that, we might get these tests and I don't understand them really. And the patient's worried and they have to wait to get to pulmonology. So even making that connection so that, we can at least tell them, okay, this is what it means. And then, once you get into pulmonology, they can explain it more.
Yeah. Absolutely. Absolutely. I think that cross collaboration is so important. That's why I love these conferences.
Thank you. Yeah, me too. And obviously we're here at RhAPP National. And so we're surrounded by such amazing rheumatology APPs. What is a key message that you'd want them to take back to their practices when it comes to ILD and pulmonary hypertension ILD?
I think just what we talked about at the beginning is, asking the questions about if your patient has scleroderma or myositis, RA, lupus, Sjogren's, yes. Those are big ones that, just every time you meet with them, ask about some pulmonary symptoms just as a screening and listen to the lungs. And don't sweat all the plumbing and all the stuff that I talked about too much. Just get some PFTs if you feel comfortable, a CAT scan, those scleroderma patients, the echo. So all of those simple things that you guys already know how to do, and then reach out to your colleagues if you have some suspicion for one of these.
Well, I can't thank you enough. Again, I know it's super complicated and complex, and it is still for me, but you've made it easier for me to understand. So I really do appreciate that. That kind of wraps up our episode of RhAPPcast. So a huge thank you again to Jessica for bringing her insight and expertise today to our conversation on ILD and PH-ILD, and reminding us just how impactful the collaboration between rheumatology and pulmonology really is. This has been such an incredible conference, full of education, connection, and the kind of energy that fuels real change in patient care. If you're not here with us this year, don't worry, we're already planning ahead for next year. So please mark your calendars for 2026 RhAPP. We will be in Las Vegas, Nevada, where we're going to bring the heat to the desert and even more cutting edge education, community, and fun. Until next time, thank you for listening.